I work in London, and I'm going to talk to you about cardiogenic shock. So I have a fair few conflicts of interest. Probably the most important ones here that actually matter are the fact that I have received honoraria from someone like GE to teach ultrasound. So therefore I'm going to be very biased in favor of ultrasound. But I will come on to that a little bit later. This is basically a summary of what I'm going to talk about, but before I get into that, I would just like to give a big thanks to my mentor, who taught me pretty much everything I need to know about cardiogenic shock. His name's Alistair Proudfoot, and he works in Barts Hospital in the UK, and he's pretty good at what he does. So, and he's on Twitter at ICU.AP. So if anyone's got any questions, he's a good guy to talk about. So, if you're going to take a photo of one slide, this would be it. This is basically all you need to know about cardiogenic shock. You have a low cardiac output and lots of badness associated with it, and it's pretty bad. When you have somebody in cardiogenic shock, you need to call for help, and you need to call pretty much everyone in the kitchen sink, and make sure that you try and treat the underlying cause. So the best way I thought I would illustrate this was to present a case, and this is a real case that I was involved in. So many moons ago, a 6-year-old chap, it presents to a local hospital that I worked in, a district general hospital, and he presented with acute shortness of breath and fevers. And this was his chest x-ray, and I don't know if all of you guys can see this, but there's kind of some right upper lobe consolidation here, and so in this area, somebody presents with a chest x-ray that looks like that, and a history that looks like that. It's code sepsis, right? So, he got 30 per cc of fluids, he got antibiotics, everybody's kept so inefficient where I come from, for some strange reason. So he got that. However, he didn't really get any better. And over the next few days on the wards, his oxygen requirements kept going up. Randomly one night, he had a bit of chest pain, so he got a troponin. We found out the troponin was elevated. This was thought to be a sepsis-associated myocardial dysfunction. So he got transferred to the ICU where he was treated as septic shock, and he got some inotropes. This is quite interesting because there was this little bit in his history, it was literally just one line in his history that everybody seems to have kind of overlooked. So he was actually being regularly echoed every 6 months because he was known to have a mitral valve prolapse. But hey, he's got sepsis, so let's continue to treat for sepsis, right? So at this point in time, I thought I'd stop a little bit and actually start talking a little bit about the science behind cardiogenic shock. So this is the actual formal definition of cardiogenic shock, and there's been a recent AHA kind of meeting of minds where they sat down and they derived some consensus guidelines on how to manage it. And this is their actual definition. Problem here is there's no actual formal definition for a low cardiac output state. So if you read lots of different papers, some papers will say you need to do a formal cardiac output measurement either with an echo or with a Swan-Ganz catheter, and they'll define that as a cardiac index of less than 2.2. Lots of other papers accept the fact that most people don't do any cardiac output monitoring, and so therefore will accept, if you've got a systolic blood pressure of less than 90, that's considered cardiogenic shock. Problem with that is that's lots of different causes of shock, right? So, pretty much anything can look like cardiogenic shock. Hypovolemic shock can look like cardiogenic shock. Septic shock can look like cardiogenic shock. Obstructive shock can look like cardiogenic shock. So how do you work it out? So for me, this is actually the big thing here. So you've got a low cardiac output state, but you've also got associated multi-organ badness, and that's the time when you really have to start thinking about cardiogenic shock. And it really is a multi-organ failure type state. So it affects everything. It affects your brain, it affects your liver, it affects your kidneys, it affects your gut. And whenever you have people who they're kind of like sepsis plus. So everything's kind of falling apart, and it's falling apart really rapidly, and you're not really sure exactly where it's coming from. You really do need to start thinking maybe this could be cardiogenic. It's very important. Cardiogenic shock is associated with anywhere up to, so this is where Alistair and I actually disagreed on this. So he's a bit more optimistic, and he said that the mortality is 40 to 60%. If you read lots of papers, there's some papers that quote an 80% mortality. So this is a really serious medical emergency. The other key thing with cardiogenic shock is that the mortality hasn't really changed in 50 years. So there's something going on here. We're not quite on top of this. We've managed to reduce, arguably we've managed to reduce mortality in sepsis, but this hasn't really changed. So how do we recognize the causes of cardiogenic shock? And this is a wonderful little acronym called CHAMP. That's a good way to remember it. So it's acute coronary syndromes. It's number one cause, number one thing you've got to rule out. And then the rest of them are kind of they're more obscure. So it's hypertensive emergencies, arrhythmias, mechanical complications of MI. So if somebody's had an MI and they suddenly develop acute cardiogenic shock, the two things you need to think about are VSD and a papillary muscle rupture. And they present very rapidly. And last but not least, you have to consider pulmonary embolus. Pulmonary embolus, when you get massive obstructive shock from PE, it doesn't just affect the right side of your heart, because you've got this concept of ventricular independence. Your right and your left side actually work together. If your right side gets overloaded, your left side stops working, and you actually get shock. So it's important to think about that. Just a little slide on pathophysiology. The main concept to understand here is, first of all, cardiogenic shock is a syndrome. Second of all, it's a self-perpetuating syndrome. So once your heart stops working, once your pump stops working, the rest of your body will respond with a massive systemic inflammatory response. And it will do what it thinks is right to try and maintain perfusion to your organs. And how it does that is by releasing a shed load of adrenaline and by releasing a shed load of ADH to try and maintain blood volume and to try and improve your systemic vascular tone so that you maintain perfusion to your organs. Problem is, when your pump is not working, that's quite bad. Because what happens is your pump's not working, your systemic vascular tone goes up, and your pump is trying to work against more resistance. So then the pump fails even more. And the other thing to remember as well is adrenaline and inotropes will make you tachycardic. Your coronaries all fill in dastardly. So the more tachycardic and the harder your heart works, the less coronary filling you get, the less coronary perfusion you get, the more ischemic your heart becomes, the worse your pump gets, the less flow you have, the more inotropes you get, the worse your pump gets, and you enter this wonderful death spiral, and just keeps getting worse and worse and worse unless you can intervene and stop it somehow. It's a one-way road to death. This is quite a nice little slide, because what it shows is that cardiogenic shock doesn't just present in one way. It's actually a syndrome. And depending on where your patient is, and with the relation of the perfusion to your peripheries, the amount of vasoconstriction they have, and the amount of venous stasis they have as a result of increased volume and lack of peripheral perfusion, they can present in essentially 4 different ways, or somewhere, anywhere in between this kind of thing. So you can have some people who maintain a relative degree of perfusion, and they don't really have any organ congestion, and they're what we call the Morgan dries. And as your perfusion gets worse, and as your right ventricular performance gets worse, you get congested and you get cold. And so the worst place you want to be is down here. That's the cold and wet group. And that's your classical cardiogenic shock. And those guys do really, really badly. And you basically want to try and intervene way before they get here and try and get them back to warm and dry. The other thing about this slide is it kind of shows you that depending on where you are on this curve, there's different treatments that you can use and they'll work in different ways. So if you're wet, you probably want to offload with diuretics. If you're dry, but you're hypoperfused, those are the people that will probably respond better to inotropes. Do you guys remember these from medical school? Pressure volume loops? So don't worry too hard about them. These is just to illustrate a very important point. So the whole concept of a pressure volume loop is it's a nice visual illustration of how your ventricle is actually working and the relationship between your filling pressures and the amount of blood that's actually ejected. So when your heart works normally, you should actually have a nice fat-looking pressure volume loop. Your LV should eject a decent volume, and so this is LV volume on the x-axis, and it should do so without requiring too much pressure. When your ventricle also works really well, it should generate a nice round curve with a decent distance, and that's the amount of work, the stroke work that it's able to generate. So this is what happens when your ventricle works. When it stops working, when you go into cardiogenic shock, everything moves over to the right and it all gets smaller. So you end up with a really tight, high pressure ventricle that can only eject a very small volume and can only generate a small amount of stroke work. And that's really important illustration because I'm going to come back to this later. But here's a really, really nice video. There's actually a lovely simulation online that you can play with that has lots of really cool things like this. So this is just a little excerpt from this online simulator. I'm going to fast forward it a little bit. So if you look in the top corner, up here, there's a whole bunch of buttons that you can change, or you can change. And one of them is contractility. So right about now, he's going to start fiddling around with the contractility bits, and he's going to start reducing myocardial contractility. And And over here, you can see that this is a pressure volume loop. The big red one is the pressure volume loop of the left ventricle. The little yellow one is a pressure volume loop of the right ventricle. So as he starts reducing contractility, what you'll see is the pressure volume loop moving over to the right. And that illustrates, and over here you can actually see kind of a pressure waveform. So as contractility gets worse, the stroke work reduces and the blood pressure drops. And this is a really beautiful illustration in real time of what's actually happening to your heart as you go into cardiogenic shock. So I'll come back into why this is important a little bit later. How do you diagnose cardiogenic shock? So you can use labs, you can use imaging like chest X-ray, but the most important thing is the clinician. It's a clinical syndrome and it's ultimately a clinical diagnosis. So you need to look at these patients and you need to think about it. Otherwise, you will treat it as keftraloptin deficiency or hemoglobin deficiency, neither of which it is. Very important to think about the peripheral perfusion and try and match the patient and think about the syndrome and think about where they are. If you think about it, you have a patient who's shocked with raised white cell count, raised enzymes, and if they're warm and dry, you think they're septic, right? If they're cold and dry, you'll think they're hypovolemic. It's really important to think about this. This is where I get on my soapbox. I love echo. I'm going to argue that echo is essential in the management of cardiogenic shock. Again, Alistair and I disagree on this. He's very classically trained, he loves PA catheters, and he's really, really good. He's just a really good guy who's really good at clinical assessment. I'm nowhere near as good as him, so I need an echo. And echo is just really cool because you can actually see, you can actually visualize the myocardial work in real time, and B, you can also get some idea of the cause. So over here, you've got two different views. This is a T view of the left ventricle, which shows a short axis view at the transgastric level, and here you can basically see an LV that's really not working at all. Not only can you see that, but if you look really closely there, can you see that? So this is actually a patient who's been ill for some time, and they've actually got a degree of LV thrombus because the LV is actually static. This is a slightly different patient, and over here, I don't know if you can see this. So this is a transthoracic echo. This is the 4-chamber view. So you guys were at the POCUS workshop. I've seen a bit of this yesterday. And over here, you can see over here at the left. This is the anteroseptal. This is the anteroseptal wall, and this is kind of the posterior lateral wall. This wall's kind of moving a little bit, and this wall's not moving at all. This patient's actually had an MI, and they've got really bad stroke volume. This patient's in cardiogenic shock, but you can instantly see why, because they've got a huge portion of their left ventricle that doesn't work at all. So now we'll move on to how we manage this. And the main thing here is you need to treat the underlying cause. So the CHAMP mnemonic is really useful because you can run through them, see which of these things you can correct. There's this concept of unloading, which relates to the pressure volume loops, and I'm going to expand on it a little bit later. But in the meantime, while you're thinking about how to reverse the underlying cause, you need to support the rest of the body, support the rest of the organ systems, while you're trying to get the patient stable and fix whatever's going on. So this is a great image from a recent JACC article, and this is a group called the I Know the group. They're doing lots of great work around cardiogenic shock. And they have this great algorithm. But the big thing here is, the only thing you really need to know from this picture is this bit in the middle. So they have this concept of a shock team. So they have a group of guys who are just dedicated to managing cardiogenic shock. And if you suspect it, you give these guys a ring, and they basically come running and they assess the patient and do lots of cool stuff. And then they will basically kind of sweep the patient up, take them to a CCU or an ICU that's dedicated to the management of cardiogenic shock, where they will monitor these patients. They'll often put a swan in, they'll do serial echocardiography, and then they'll make decisions as to where this patient lies on the spectrum, on the syndrome spectrum, and start appropriate management. This is another algorithm that comes from the consensus statement from the AHA, and this is kind of their algorithm in terms of management. So once you've established cardiogenic shock, there's a whole bunch of stuff you can do. So they start off with medical management. They go on to reperfusion therapy, and that's probably the most important thing that you can do, because out of everything that we can do to treat people in cardiogenic shock, the one with the most evidence-based is still reperfusion in people who've got ischemic heart disease. So there's a great trial called the SHOCK trial, and that basically showed a massive improvement in mortality. You can stent people in and improve their perfusion when they've got an MI. If that doesn't work, then you're going down into more and more esoteric therapies, and the big thing you're going to end up with is mechanical support, at least temporarily, while you make a decision as to what you can do for further therapy. Once you're on temporary mechanical support, you've basically got 3 destinations. You get a transplant, you get a VAD, or you're done. What mechanical support does, it's not a cure. It allows you to make that decision. So before we go into all the advanced mechanical stuff, I thought I'd talk a bit about medical management. So big thing here is still PCI. PCI is really, really important. If you've got somebody with cardiogenic shock, you need to make sure, you need to absolutely make damn sure that they haven't got coronary occlusion, because that is the one thing that you can do immediately that will really change their mortality. Blood is great, it's got lots of oxygen carrying capacity. However, these guys are congested, and you give them blood, you potentially tip them over the edge, and you put them into worse heart failure. So you have to use those therapies with caution. There are some patients in whom it will benefit. So there are some patients with cardiogenic shock who are actually hypovolemic. However, their volume responsive state is actually, they have a very small window, so you need to assess with caution. The other things you can do are try and reduce myocardial oxygen. You can try and reduce myocardial oxygen demand. And here are a couple of things that you can do. So this is where your decongestive therapies come in. And you can use things like, you can use lots of furosemide. You can think about using inodilators, so positive inotropes that will actually cause a degree of vasodilatation, so hopefully reduce that massive SVR that your heart's working against. In some selected patients, heart rate control might actually be beneficial. So some people get really tachycardic. So using a little bit of beta blocker may be a benefit in a small subset. And in some patients, you can try and optimize contractility. All of these things have caveats because they all have side effects. So if you venodilate people too much, you actually drop their pressures and you actually make their shock worse. If you use inotropes are great, but they also make you tachycardic and they potentially increase your SVR, so they actually make your shock worse. So this is a really, really tight knife edge balancing act, and it's worth assessing. You still have to look at the patient. So whatever you try to do, you have to try it, reassess the patient, change it if it's not working, and reassess the patient. So literally, whatever continuous assessment you use, whether that's clinical, whether that's some kind of cardiac outcome monitoring, you just have to keep doing it. This is why I showed you the pressure volume loops. So the whole idea of that pressure volume loop is, you've seen what happens when you go into cardiogenic shock. Your stroke work just kind of shrinks massively and everything just moves over to the left. Your volumes just become, your heart loses its ability to eject. So if you could unload it and move it back into that nice, normal, happy place that it was, that would be fantastic, right? That's what all the mechanical devices that we have are designed to do. And that's literally what you want to do. And so here, so this is a patient in cardiogenic shock with really rubbish stroke work. And each of these little curves is different mechanical support devices. This is the one I'm probably most interested in because I love ECMO, and that's what ECMO does. So ECMO basically moves you way down the curve. And that's ultimately what you want to do. So ultimately, they are actually the ideal thing to treat cardiogenic shock in the immediate term with, because they're the one things that reduce myocardial oxygen demand while increasing myocardial oxygen supply. Now, I can talk about mechanical support for ages and ages and ages, and there's lots of different things and lots of different devices that people design that you can stick into various bits of the body through various arteries and various veins, and they all basically sit somewhere and they whiz around and they have some kind of pump bit to them, and they've essentially decompressed the left ventricle or the right ventricle, or both of them, while improving general blood flow and improving oxygenation. And they're great, and we can have, people have big, long seminars about these things, and they spend a lot of time talking about the rather substantial evidence base that shows that they work. There isn't any evidence that they work, sadly. There's no evidence at the moment that any mechanical support device actually improves your mortality up till today. And that's a rather humbling thing. So even though we use these things, they essentially a bridge to something else. They're not a cure. And this is an interesting extension on what Rory and Felipe have been talking about. All this stuff, you still have to treat an underlying cause. So, back to our case. So patient is now in ICU for 4 days, getting worse. New clinician comes along and goes, they're kind of cold and wet. This doesn't fit with sepsis. So we're doing echo. So I don't know if you guys can see this. So here the left ventricle looks like it's working really well, right? So this looks like normal. You don't think that's cardiogenic shock. Can you guys see the mitral valve here? So this is the posterior mitral valve leaflet. Can you see that it doesn't meet? So that's his mitral valve prolapse. So I put some color over it. Can you see all that red, all that stuff, all that turbulent stuff going backwards into the left atrium? I'll show you a better view. So this is a 4-chamber view. Can you see how much stuff is actually going backwards? So that's what severe MR looks like. The other thing here is, if you look up here, so up here is actually the right upper pulmonary vein. So he's got really bad MR, and the jet's going all the way back into the right upper pulmonary vein. The right upper pulmonary vein is the right upper lobe, and so therefore that's why he's got consolidation in the right upper lobe. If it wasn't consolidation, it was unilateral pulmonary edema. So yeah, so the interesting thing about this is, so that if you did just a point of care echo, you'd think this heart was normal because the ejection fraction looks fine. However, the ejection fraction is not fine because most of that blood is actually going backwards into his left atrium. So his left ventricle is under no load whatsoever because there's no blood in it. So this is what happened to him. So the moment we found this out, he basically got a balloon pump, and we transferred him from our little local hospital to the nearest cardiac center. Sadly, it was too late. He was persistently febrile, so we think we actually did, he probably got a hospital cardiac infection at some point. So he couldn't get a valve replacement, and he just got worse than cardiogenic shock and he didn't make it. So that's it, a little cautionary tale. It's bad stuff, cardiogenic shock. Get it early, get some help, and do something about it.